I would like to thank the Pan-Arab Society for Fertility and Genetics ممثلة برئيسها الدكتور مروان حلبي لهذه النشاطات المستمرة و tackling difficult issues and difficult subjects. One of them which we're going to talk about tonight. الصراحة is a very important topic, yet very controversial and yet very highly required in our part of the world. The first talk will be presented by our dear speaker and friend, Dr. YACOUB KHALAF. Dr. YACOUB KHALAF is well known to our part of the world, with the Arab world, ودائما بيساعدنا and he helps us all the time, but he's also an international speaker. Dr. YACOUB KHALAF, Professor of Reproductive Medicine and Surgery at Guy's and St. Thomas's and King's College in London. He is the former director of the Assisted Conception Unit and HFEA responsible in 2004 ل 2019. He is also director of the pre-implantation genetic testing program.
كفاية دكتور خلدون، كفاية.
طيب, all I want to say, Dr. YACOUB, is that we are very proud to have you tonight with us, and you always give time for our part of the world, and every time we invite you, always happy to help, and we appreciate that. Dr. YACOUB is going to talk to us tonight about a very controversial subject, which is going to be about ovarian rejuvenation, a hope or mission impossible. So, Dr. YACOUB, the floor is yours. Thank you.
Thank you very much, Dr. Khaldun. I did hardly hear anything of what you said, but all I can say, it has been a very long introduction that was totally unnecessary.
Okay.
I can't begin to give my talk without thanking Dr. Marwan, اللي هو مثال يعني في دماسة الخلق وفي التواضع وفي العمل الدؤوب للحاجات اللي تنفع الناس، واختياره للموضوعات اللي هنتكلم فيها النهارده بيعكس ده. لأن we are as practicing clinician, we don't do medicine to inflate our ego. We do medicine to help patients and help patients with honesty and integrity, and exercise our best judgment to support them to be going in the right direction. This is an example of the topics that where things can go either way. Either we give them the right message, or we support them or mislead them into the wrong direction. So I will be talking about ovarian rejuvenation as it's been introduced, and that is something that is capturing the imagination, particularly in our region. And why are we in this desperate situation? Because our patients have high expectations. That's no matter whether they are well educated, not so well educated, whether they had a baby before or they didn't, their expectations are usually much higher than reality. Despite also our best efforts and the progress that is happening with IVF, the success rates remain modest. At best, in a general program, 1 in 3 of the patients who come for treatment will leave the clinic with a baby. The other 2 will have to try for a little bit longer. Also, the bit that doesn't help, there is a huge amount of commercialization in the World Wide Web, and sometimes it inflates the reality and make it sound too much of fulfilling everybody's dream, which unfortunately is not the case. Patients also feel that they can buy, or some of them can buy anything, and because they are under pressure and they are prepared to pay anything, even for the hope. There is also emphasis on technology, because we are all the time being reminded there is huge advance in technology here and there, and we might just touch on that. People, either they don't appreciate that biology is more important than technology, or they don't wish to believe that. The other issue is that in our field, people will suggest some interventions and they will apply them straight away without examining them objectively and ensuring that they deliver, not just they promise. And some of us are reluctant to change their practice, even if an evidence has appeared to show that an intervention does not work. They still practice what they have always done. So how important biology is? Here is just a bit of a simple or simplified explanation of how biology works. A younger woman probably will be born with large number of follicles and large number of what we call egg reserve, because they haven't lost much of it, just a tiny bit. But this hourglass will change for someone who is not as young, where you will find that most of the eggs have been already used and what is remaining is modest. So the expectation will need to be proportional. And in the extreme, you will find that most of the eggs have been consumed and hardly there is anything. And that's what we do when we try to do ovarian rejuvenation. Just, I need you to hold this thought, because if there isn't material to work in, what would the rejuvenation do? So when we look at all the results of IVF, regardless where it is done, whether it is in Cairo or in Kuwait or in Mozambique, always the chances of success are related to the patient or the woman's age. This is the American data. They use every bit of technology. Yes, it may have been a few years back, but it's no different now, as I will show in a minute. And patient of advanced maternal age, as we call it, 43, 44, older than 44, even with the ultimate technology, they need to appreciate that the chance is modest, so that they save their money to have more tries rather than spending them on intervention that promises but don't deliver. I give you an example of the impact of technology. Here is a period between 2006 and 2015 period. For younger patients, the chances of success is increasing with time over the 10 years. For older patients, because they don't have the ovarian reserve that sustain any progress, it remains a straight line for patients who are 40 or above 40, or even for above 44. This is the most recent published American results. People, particularly patients, may not appreciate that in the United States, following 51,000 cycles for patients under 35 years of age, the average patient will have a chance of 37%, 1 in 3, of leaving the clinic with a baby. This becomes much less if the patient was 38 to 40, where the chance will be at best 1 in 5. And if the patient was above 40, you're talking about 1 in 10. Still, patient will hold on to hope, no matter how modest their chances, and they are preparing to pay for that hope. And there are two ways: either we exploit that wish, or we either use it judiciously. And so that is the fundamental question. Can we beat biology? Can we rejuvenate the ovaries? But in order to know what we are talking about, what do we mean by rejuvenation? If you look at the dictionary, it will tell you that rejuvenation is to make young or useful again. I'm sure I'll be the first to use any agency to make me young and useful again, but that is easier said than done. Or to restore to an original or new state. If you apply this to the egg reserve, for instance, having shown you the hourglass, can anyone really reverse that? I leave it to you for now. People don't appreciate that the ovaries are very interesting organs. Here is a cross-section in a child ovary. At age 10, look at the density of the follicles and the eggs. Age 20, look at how the density has become less. Look at age 30, how the density become even less and less. So this is a progressive process until patients reach the menopause, where they will have few hundred follicles that are hardly sensitive to any stimulation. That is about the quantity. How about the quality? Can we rejuvenate quality? And if so, how? Here is the age-related fertility decline, which is associated with also, in the opposite direction, increased rate of miscarriage. And here is the age-related decline in the chances of success using own eggs, which can be only helped in the Western society by using donor eggs, where suddenly this very downward trend become a straight line. So you only replace eggs with eggs. Anything else really need to be put into some perspective. So what are we trying to do when we talk about ovarian rejuvenation? Are we trying to turn the clock back, where a 45-year-old or a 40-year-old will be made to have an egg reserve of someone who is 25? Is that possible? If the answer is it is not possible, then thinking of rejuvenation in the way that we think is almost mission impossible, because you cannot improve the quantity because that is finite, the patient is born with. You cannot improve the quality because that is deeper than just putting any cocktail to help the ovaries. It is more chromosomal and more of some issues to do with aging. So what can we use, or what is being used to rejuvenate the ovaries? From the mitochondria, whether it is of the same patient or from other patients, to activation of the follicles, to using stem cell therapy. Stem cell therapy come into different ways and means, and I will not touch anything other than PRP as mesenchymal stem cell therapy, but the rest will be handled by my friend and colleague, Professor Johnny AWWAD. When people talk about PRP, there is a huge amount of marketing and exaggerated expectations. And that is with all the interventions that are introduced in IVF. They will say, this treatment will make your grandmother pregnant. Then there will be the exaggerated expectation. And once people tried it and they showed categorically that it doesn't work, then we get into the trough of disillusionment. And unfortunately, we tend to repeat the same thing time and time again. So for the plasma, the platelet-rich plasma is used to the so-called endometrial rejuvenation, ovarian rejuvenation, and for erectile dysfunction. And of course, it is used in non-reproductive medicine indication, in orthopedic or in sports medicine, etc. But I will not be talking about uterine use of PRP. I will be just focusing on ovarian rejuvenation, or the so-called, which has been questioned whether it's a brighter side towards all lost hopes or it is maybe a snake oil. Some of the headlines in some of the British media back in 2018, hope for pregnancy after menopause with ovarian rejuvenation, which involves poking the organs with needles. Everybody was excited, like the tabloid or the media would like to run wild with any intervention. But when we look at the truth of the matter, you will find that the research, when it was started, this study was registered in 2016. And so far, I have not seen any result for this study, which would have been fine because it's randomized controlled study. We didn't. We saw adverts in very big places like IVI or EV in Spain, a big organization talking about ovarian rejuvenation, strides toward fertility treatment. But if you go into the website, you will find them being honest. They say, this is something that is in progress, but our best advice for you to consider using donor eggs, because in some societies that is allowed, acceptable, and successful. Just to put things into context, this is the account of one of the patient who used PRP because she didn't have period and wanted to try to become pregnant. She said, I had PRP done in November last year, and my periods were normal, although they varied between 28 and 38. I now had my last period in June 28, that's maximum 6 months, and then wondering, has the benefit of this surgery stopped, or the time frame for how long it assists? So you can see people get the reactionary effect of injecting the ovaries by anything, and unfortunately they are giving hope that this hope will be dashed and will lead to nothing. Now we're talking about serious work where there is a study, a preliminary report of intraovarian injection of PRP in extremely poor prognosis patient with only oocyte donation as alternative, a prospective cohort study. To cut a long story short, no clinically significant effect of PRP treatment on ovarian function were observed over 1 year of follow-up. Another recent study that was published last year in 2024 in Human Reproduction and from a credible group of investigators, including Richard Scott and Emery Silly, who showed interest in this and published some preliminary data, but luckily they did the proper thing, which is randomized controlled trial, and says intraovarian PRP injection procedure does not improve mature oocyte yield after controlled ovarian stimulation in women less than 38 years old with an established IVF history of poor ovarian response or reserve. So we have seen when people start to do the decent work, the truth has become apparent. And there is a review article in RBM Online that looks at the studies that have been published about PRP. And when you read them, really, you can figure out all that is wrong with how interventions are assessed, because the majority are case series, retrospective studies, and lots of wild claims that have not been substantiated. Again, it is exaggerated expectation leading to disappointment and starting all over again. When you see articles for people who are excited about PRP, you need to read carefully, because when you read their thesis, they will always cite work that is very emotive. Here it says platelet carry more than 800 types of protein molecules, cytokines, hormones, and chemoattractants. That's very encouraging. If they have all of this, surely they must have an impact on the ovary. Look at the reference for this statement. It is principal method of preparation of platelet plasma. It is in Journal of Cutan Aesthetic Surgery. So it's totally in a different context. Maybe in aesthetic surgery for cartilage, for bone, maybe, but nothing to do with what we are talking about. Then they use the same language. The activation of platelets induce the release of a variety of biologically active proteins which stimulate cell proliferation and growth and differentiation. Again, look at the reference, American Journal of Sports Medicine. Nothing to do with finite resources like the eggs, but still for the uninitiated reader will not take hold of these facts. Then, last year in 2024, Cochrane showed interest to assess the evidence that exists. And Cochrane is credible, something that we look up to for assessing the evidence that exists in the literature. What did it say? When they looked, they found 12 studies. Only one of those 12 studies was having low risk of bias, not completely free of bias, low risk of bias. The rest, what happened to them? They failed to report live births. They have poor reporting of methods. They lack prospective protocol registration. They didn't have any precision because they use small number. They have been indirect due to specific, due to the specific subpopulation that they used, and there was insufficient or absent safety data. You hear from some our colleagues, they say patients develop abscesses as a result of injection of PRP. Rare, but one is one too many. They have made a summary, the Cochrane review, that said, we are uncertain about the effect of intraovarian PRP injection compared with no intervention on the ongoing pregnancy rate, because there is no significant difference, very low certainty evidence. On the clinical pregnancy, the same, there is low certainty evidence. The study examined no safety outcome, so safety is not important to people who use it. Just to give you an example that I used before, this is one of my patients who happened to have poor ovarian reserve. Her AMH was 0.7 nanogram per ml, per liter. Here, she had 6 or 7, 1, 2, 3, 4, 5, 6, 7. And these are real life months. one in December, one in January, one in March, one in July, one in August, November, December. Same sitting, same center, same doctor, same protocol. Look at what happened in one cycle. The first cycle, she had 4 eggs. She ended up with 4 blastocysts. The second cycle, she had only 2 eggs, no blastocysts. The third cycle, she had only 1 egg, 1 blastocyst. The next cycle, she had 6 eggs, 3 blastocysts. Imagine if after this one was her first, and we gave her PRP here, and she had 3 blastocysts, that's 300% improvement. We would have attributed it to PRP. When it did happen without changing anything, the same protocol. And the following cycle, same protocol, 2 eggs, 2 blastocysts. 3 eggs, 3 blastocysts. 7 eggs, and 5 blastocysts, and so on and so forth. So you can see that this biological variation is lost in translation when it comes to studies that are of poor design. How about AI? AI is a new kid in the block now, and everybody is thinking that AI will change the world. It could, but currently it could be misleading. But it helps us in definition, because if I tell you that my patient had improvement in outcome by chance, if you ask AI, it will say in medical research, chance refers to the possibility that observed results in a study could be due to random variation rather than a true effect. This is why researchers use statistical method to assess the likelihood that the result occurred by chance and determine the level of confidence. And that's what we say, or what we mean when we say randomized control trial. You have patient with low ovarian reserve, poor response to stimulation. You randomize them to half that will have PRP, and the other half will be control. You follow them up, and you will have registered your protocol before you start recruiting the first patient. You have been clear about intervention, you have been clear about the outcome, and then you compare the result. Only then you will be presented with credible evidence, not affected by random chance, not affected by bias, affected only by the truth, the whole truth, and nothing but the truth. So that is the good side about AI. But if you ask AI about PRP, see what it tells you. Fertility doctors use platelet-rich plasma to potentially improve patient chances of pregnancy by enhancing the lining of the uterus, promoting blood flow to the ovaries, as if the issue is blood flow, and potentially improving egg quality. Where are the eggs to be improved? If the patient has run out of eggs, where are the eggs to improve? Egg quality, particularly in cases where a woman has diminished ovarian reserve by stimulating cell growth and regeneration. So the AI is regurgitation, is just doing the act of regurgitation of what is being fed from the different commercial organization publishing in Google, because it extracts its information from what is being published. And that's why nowadays there are books already available to talk about what you need to know about AI and how to defend yourself against bogus AI claims and products. I don't know the author, I'm just picking it out of the internet to show you that we need to be careful about what we read. So I hope that I have explained that what is claimed about PRP is unsubstantiated claim. And if you wanted to go for the old description from that infamous man, it is nothing more than fake news. If something is too good to be true, you should not believe it. If something says that poking with platelets into the ovaries will make the patient young again, should not be believed. Can we beat biology? Can we rejuvenate the ovaries? The answer is no. What do people rejuvenate? They rejuvenate their bank accounts, because they charge huge amount of money, inordinate amount of money for PRP. If the patient can get something in return, fine, they can charge what they like, it is a contract. But as it doesn't deliver anything, can people justify to their conscience that they continue with this practice? Here is in Europe, where research is done, where the truth is reached, probably in an objective way. What is happening? There is an exponential rise in the business of egg donation. if ovarian rejuvenation has any role to play, why the only definitive treatment for those people using donor eggs is rising exponentially, because that is the only way you can replace eggs with eggs. I can understand in our region, there are religious reasons as to why this is not allowed, but just because people can't have other options, it is not a license for us to give them anything and everything and get them fleeced out of their money for the false reason. So, ladies and gentlemen, thank you for following this discussion, but my take on ovarian rejuvenation as it is practiced now, A, it is misnomer because we cannot turn the clock back. 2, it is misleading because we promised what we don't deliver. And it is misused because a lot of money is being paid for something that has not been objectively shown to work. And it is nothing more than mission impossible. So we need to stop and think, are we really doing favor to our patient or to ourselves by going blindly with unsubstantiated claims and using treatment that does not add value? It adds suffering, because the patient could invest the money on that uses for PRP on undergoing another cycle of IVF. Thank you very much.
Thank you very much, YACOUB, for excellent presentation. And we will leave the questions to the end of the session. I encourage my participants, please, our participants, to put their questions in the Q&A section.
It will be good to work on the sound because I can barely hear. So for the question, I need some help.
Apparently, everybody can hear me, YACOUB. I don't know. I mean, Dr. Hazem, can you hear me?
Can you try, Hazem? Hazem, you are mute.
Well, I think, Hazem, you need to unmute you so you can present our next speaker.
Yeah, fine, but just fix the sound.
Yes. Okay, Hazem, can you hear me, Hazem? Can you hear me?
Yes.
Okay,
yes,
apparently YACOUB cannot hear me, apparently. Tonight.
I will try my best. I will try to get
so now
some
we
headphones.
get Hazem. Yeah, thank you, YACOUB. I would like to invite Dr. Hazem to present our next speaker. Thank you, Hazem.
Yes. First of all, I'd like to thank the organizers, the Arab Federation of OBGYN, for organizing this important actually webinar, especially the topic, and also the good selection of good speakers to tackle these important two issues.
I got the diagnosis now. Sorry.
Okay, so maybe yes, that's what you need now. So I'd like to thank the first speaker, Dr. YACOUB KHALAF, for a very good presentation about the stem cells in ART. And now to complete the picture, I'd like to also introduce my friend and Professor Johnny AWWAD, who is also known to everybody. He have a long CV, so I have to cut it short. Johnny, please. He's the executive chair of Women's Services in the division and division chief in reproductive medicine in CIDRA Medical and Research Center in Doha, Qatar. And he's also a professor in obstetrics and gynecology and a founding head of the division of reproductive endocrinology and infertility at the American University of Beirut Medical Center. He's also founder of the cryopreservation and pre-implantation genetic program at the same institute. And our Professor Johnny AWWAD, he will be tackling with stem cells, novelties in ART, facts and fabs. So Professor Johnny AWWAD, the floor is yours.
Thank you very much for this great introduction. It is going to be very difficult to follow suit now that Professor YACOUB KHALAF has presented this wonderful presentation. Can you see my screen?
Yes, yes.
My slides, perfect.
Yeah.
There is not a single week in my own practice, and probably in yours, without having a patient walk into the office with a consultation done in the region or elsewhere, asking, coming to counsel, to obtain a counseling regarding the use of stem cell technology because of difficulty conceiving. And most of the times, these patients come in with either premature ovarian failure or insufficiency or poor ovarian reserve, and they've been advised to do stem cell technology. I have a few who go to New York to do stem cell technology, or to parts of Spain, or sometimes other parts of the world. And it's very hard, like Professor KHALAF said, to convince them otherwise, because they are desperate and they have to use anything that could potentially be beneficial to them. So I have nothing to disclose. So then the coming few slides, and we're going to share together what is today stem cell technology, what's available, what's probably coming over the next 5 to 10 years. And of course, we all agree that human reproduction is frustratingly inefficient compared to other mammals. We know that the chance of implantation of an embryo, a human embryo, is no more than 15 to 25%, as opposed to 95% in rabbits, for example. That's major, that's huge. That makes us, in fact, inefficient breeders or slow breeders as humans. But even after we adjust for age variations, about 1/3 of natural conceptions would lead to a successful live birth, because we know that about 85% of all unsuccessful conceptions would stop somewhere, right? Either at the time of implantation or shortly after. So that's probably part of it. Now, it gets more complicated when women start suffering from a decline in reserve, and we call it the gold reserve because it's irreversible. Once we lose it, there's no coming back, at least as of today. But I have shared now this network meta-analysis to show you how many interventions have been put out there and the quality of the data that are there. This is a network meta-analysis showing 36 different interventions and therapies for women with recurrent implantation failure, for example. If you look at many of those show promises, right? So if you base yourself on studies like this, you would think that this finally the problem of human infertility has been completely resolved. But I think the most important message here is that we have to look at those at these studies and look at their quality, look at their design, and then make a judgment based on how well this evidence has been presented to us. So what are mesenchymal stem cells, or MSCs? These are essentially multipotent adult stem cells. They have the capacity to self-renew. The earliest product was approved by the FDA in 2011. But shortly after, within half a decade, more than 350 US companies commercialized stem cells and offered it to more than 600 clinics in the span of just 5 years. And these are applications not only to reproductive medicine, to different and various parts in our medical field. And clearly, within 5 years, there is not sufficient time to build evidence to show whether these stem cell technologies, in particular applications, are beneficial or not. Now, in 2023, if you look at the clinical trial database in the United States, NIH, US, you see that about 1,500 MSC studies are currently in process. So there's lots of interest in that, but at the same time, there's always a risk of commercialization and overrating the benefit of these treatments. The International Society of Cell Therapy has set some criteria as to how to define these mesenchymal stem cells. They define them based on their morphology, on their expression or lack of expression of certain cell surface antigens, but also on their ability to differentiate into osteoblasts, adipocytes, and chondroblasts, and sometimes as well cardiac cells. Now, when it comes to their migration pattern and we infuse them into the bloodstream, the most concerning part is that they can localize to just anywhere in the human body, right? Although there has been some studies to suggest that they mostly home to diseased and damaged tissues, and they home to native niches. For example, if you are infusing bone marrow MSCs, they tend to go to the bone marrow, but they can land anywhere. Now, one of the major misconceptions in our field is that when we inject MSCs into the ovarian tissue, they have the ability to differentiate into follicles and oocytes. But that is, in fact, not true, because the fact is that these cells migrate to the site of injury only to produce bioactive factors that appear to stimulate some residing stem cells in that particular tissue that could potentially improve tissue repair and reduce apoptosis. So the misconception that these cells will become cells as part of that diseased tissue, at least in the ovarian tissue, does not hold true. So there's been lots of interest in using these MSCs in various animal models, mostly in the mouse and in the rat. These animal models essentially have been reproduced by subjecting these animals to chemotherapy. So they induce a form of premature ovarian insufficiency, which is very similar to what happens in humans, but naturally. And when these MSCs from various sources, bone marrow, peripheral blood, adipose tissue, were injected, some of them have shown some improvement in ovarian function. But these were measured essentially on the basis of the number of follicles and the AMH expression of the ovary. Very little has been done to demonstrate an actual improvement in the success rate, that is the final reproductive outcome like live birth in these animals. And therefore, the surrogate measure of pregnancy or of an outcome, which is the number of follicles, is not necessarily indicative of a success at this stage. Now, this is a study, again, looking at the use of these mesenchymal cells in improving ovarian function in premature ovarian failure in preclinical studies. And as you can see here, this is a kind of meta-analysis putting together all these animal preclinical studies together and showing a significant improvement in estradiol production in these animals, an increase in AMH production, a reduction in FSH production, and an increase in primary and secondary follicles in these ovaries. These are 37 studies, including almost 1,000 animals. So there's something there that's working, at least in the preclinical studies. Now, of course, there have been some interest recently to translate this research into clinical studies, but the registered trials are still limited. There are about 10 of them, at least as of last year. And in many cases, these interventions were shown to restore ovarian function, again, based on surrogate measures of success, that is follicular development or AMH production, right? So the quality of the data is very limited. Now, where do we get these mesenchymal stem cells? We could get them from the human bone marrow. This is the first source of stem cells which was utilized in animal rats to improve the outcome of premature ovarian failure. And these protective effects which were shown in that model appear to be of a transitory nature because of the loss of transplanted cells. This is very similar to some of the studies that were done in the past in humans by the Spanish group, by Evie, in trying to improve the endometrial thickness in women with endometrial injury or endometrial synecdoche, in which the benefit was shown to disappear within the span of a few months. You could use amniotic membranes as well to produce, to generate mesenchymal stem cells. These are essentially known for their high expansion potency, but most importantly for their anti-inflammatory and anti-fibrotic properties. That's why there's been lots of interest in using them, mostly for endometrial rejuvenation in women with endometrial injuries. Umbilical cord could be used as well. The potential, the benefit of it is that it can differentiate in 3 different germ cell layers. It has a relatively higher safety and shorter expansion times, and they have low immunogenicity. But there has been growing interest lately in using these MSCs from adipose tissue because of their easy availability. Many people undergo liposuction or abdominoplasty, and there's huge chunks of adipose tissue that are used to extract these MSCs. Now, because of the abundance of MSCs in these big chunks of tissue, there's less need for long-term culture and passages, and therefore there's a higher genetic stability and a lower risk of chromosomal abnormalities in these tissues. I'm going to share with you two clinical studies just to give you a flavor of the quality of these studies that's been out there, and just to help us share these data with our patients and counsel them properly. This is a study from the United States. It is an approach called ASCOT, which is autologous stem cell ovarian transplantation, right? A big name. So this is a prospective observational pilot study, right? So this is not a study that has any controls in here. And on a small number of patients with poor ovarian reserve, with ill-defined definition of poor ovarian reserve, so 17 patients. These patients were treated with a granulocyte colony stimulating factor for 5 days. That resulted in mobilization of their MSCs from the bone marrow. Then they collected these stem cells by apheresis, and they delivered them through the ovarian artery to one of the ovaries through a catheter, while the other ovary acted as a control. Now, several weeks later, these women underwent ovarian stimulation, and they underwent in vitro fertilization. As you can see here, these patients acted at their own controls, and we are all aware of the limitations of studies like this with absence of a true control. But you can see clearly here that the AMH in the pre-treatment group increased significantly after intervention or treatment. The antral follicle count increased significantly as well, and the cancellation rate when they underwent in vitro was decreased from 29 to 14%. Again, there are lots of limitations in using this form of model, especially with a small number of observations. But what is also interesting is that while in previous attempts, there were no embryos that developed out of the oocyte collected. However, after the ASCOT, there was a possibility of finding one embryo from the unilateral ovary and another embryo that came from oocytes from the contralateral, which is the untreated one, which is also of interest, which means that although you deliver the treatment to one ovary, but like we discussed earlier, these cells will simply disseminate in the body indiscriminately and will go to the other ovary and other tissues as well. So in this particular study, with its lots of limitations, of course, the ASCOT was shown to show some improvement in the antral follicle count within 2 weeks of treatment in 81% of women. It appeared to increase the number of antral follicle count and oocytes. 5 pregnancies happened, but 3 of them by natural conception, right? But the interesting part is that the euploidy rate in these patients was 16%. So there is a message to take from here that if these MSCs improve the environment of the ovary to improve the number, they do not improve the quality of these oocytes. So 16% euploidy rate is significantly low. Here's another non-randomized clinical trial again, in which human umbilical cord mesenchymal stem cells were used in women with premature ovarian insufficiency. These are young women, less than 35, with previously irregular menstrual periods and a history of amenorrhea for at least 4 months with elevated FSH exceeding 25 in at least 2 different occasions. So 61 of these patients were treated by direct injections through ultrasound-guided needle directly into the ovaries. And the primary outcome was the number of matured follicle per month. Again, it's very ill-defined, very subjective, nothing like pregnancy rate or any other sort, right? So this is one of the limitations of these studies. And what they found out that there's a group of women who, in fact, had an increase in follicular development and egg collection. And when they evaluated this group of women, it was shown that women with a shorter duration of amenorrhea, that's a recent onset of POI, were more likely to respond better to the treatment. And women with a higher baseline AFC, that's higher follicular reserve, appear to respond better. Now, that in itself tells us, one, it is not known whether it is the mesenchymal stem cells that cause the improvement in this subgroup of women, or is it the natural course of the disorder? Because we know that these women, especially those women with a recent onset of or acute onset of ovarian insufficiency, they go through waves, through fluctuations where antral follicle count could improve over a month and then decrease over a month, and the response can vary before finally they settle into an ovarian failure. It is not also known whether it was the traumatic injection with a needle rather than the MSCs that has caused this improvement, right? So this is part of the studies that are actually over there. So what are the challenges and limitations of MSCs? First, the cell sources are very difficult to find. The purification is very challenging. The quality control is very challenging because when you get these MSCs from cord blood or from bone marrow from different people, the quality is different from donor to another. There's a safety issue. Although their immunogenicity as cells is very low, but anytime you infuse cells or inject cells, there's a risk of immunogenicity, risk of microbiological contamination, most importantly, emergence of dangerous clones, whether teratomas or any of the sort, as a result of genomic instability. Because of that, over the past decade, there's been interest in utilizing extracellular vesicles that are derived from these MSCs. Now, these are nano-sized transporters. They could be proteins or non-coding RNAs. And they're responsible for the therapeutic effects of MSCs because they act as intercellular messengers, right? So the benefit are twofold. One, there's less risk of tumor formation because they're not cells, and there's less immunogenicity, again, because the absence of cell components. This is a meta-analysis of preclinical studies, animal studies, that have shown here, as you can see, in rats or animals with induced premature ovarian insufficiency, that these EV therapy appear to improve AMH production. So there is something there to explore. And in other animals, when you look at those in which endometrial damage was induced, EVs appear to increase endometrial thickness after 2 weeks of treatment. Again, surrogate measures of success, but again, there's something that is there. And I would like to conclude with a word about induced pluripotent stem cells we refer to as iPSCs. Now, induced pluripotent stem cells are adult somatic cells. They could be any cell in our body, which are reverse programmed. And now they have a similar capability of self-renewal and differentiation as embryonic stem cells, except they are patient matched. So they come from our own body. They can propagate indefinitely. So there's an inexhaustible source that can meet high clinical demand. And most importantly, you do not have to deal with the ethical concerns that come with embryonic stem cells because they come from our own adult stem cells. And there's a very interesting study that I would like to share with you and conclude this presentation. I've worked closely with John Telly at the Massachusetts General Hospital some 2 to 3 decades ago. His lab was next to my office, and we had lots of discussions. And John Telly was the first one to publish in Nature, if I'm not mistaken, that big study that showed that you could actually produce or cause stem cells to differentiate into what looked like oocytes at the time, except these oocytes were non-functionals and could not produce embryos at the time. It took science about 2.5 decades to come to this study. And this study is from the Brigham and Women, from a very close friend of mine, Raymond Anshin, late Raymond, because he passed away a few months ago. A great study, right? And in this study, what the investigators did, they took granulosa cells from the mouth. They reverse engineer them, reprogram them to produce these iPSCs, right? And what they did, they injected them into the ovaries of mice which were treated with gonadotoxic agents. And what they did as well, they used fluorescence-activated cell sorting in order to purify them into two groups. Those are less differentiated and those that are more differentiated. The more differentiated were defined as those that expressed AMH receptors. And what they did, they injected them into those mice that are chemotherapy treated, into the ovaries of these mice. The sorted iPSCs were found to differentiate into de novo oocytes, as you can see in the upper part of the picture. They look typical like oocytes and follicles. And then when they ran immunohistochemical studies, they did find actually they did find markers, ovarian markers, that localized to the theca and to the granulosa cells, namely FSH receptors, inhibin receptors, AMH receptors. And they did find oocyte markers, typically ZP2, DAZL, and all of these. The interesting part is that when they incubated them with 5% human follicular fluid, it could trigger steroidogenesis by production of estradiol synthesis and progesterone synthesis as well. And that was very remarkable. So when they injected the undifferentiated cells into mice, they formed teratomas, as you can see in the picture. But when they injected sorted ones, the more differentiated form of these cells, there was no formation of teratomas. And the interesting part is that when they injected them into the mice which were pre-treated with gonadotoxic alkylating agent and rendered infertile, and then these were bred with male mice, right, through in vitro fertilization, they produced pregnancies with sizable and viable fertile litters, which means these litters were able to reproduce up to 3 generations. And when they performed STR analysis to look at their lineage derivation, they could track them to these iPSCs. And that was, in fact, this is very revolutionary because with that, there are 2 potential benefits. If researchers pick up this research and develop it in humans, confirming its efficacy and safety, which would probably in the next 5 to 10 years, if it turns out to be successful, can really bring 2 main benefits to humans. One, restoration of endocrine ovarian function for women who are not interested in future fertility, but they're interested in expanding their endocrine function. That is, extend the time of menopause so that they stay in the premenopausal status and protect their heart, bones, and remain active. So that's a potential benefit over there. Or for women who do not want to lose the opportunity to get pregnant at a later age if their health allows them to. I conclude with this one, and I thank you very much for your attention.
Professor Johnny, thank you very much for elaborate lecture on this important topic. And I mean, I think we have a question from one of the audience. Says, is it true that there is a chance that stem cells change to cancerous cells with division? It means they are worried that this use of this technology might change to tumors in the future. So it's yours. This is for you, I think, Dr. Johnny.
Yeah, I totally agree. And as I've seen, I've shown in some of the studies, the main concern is that they can go into uncontrolled type of differentiation and cell lineage, including teratomas and sometimes other malignancies. So that is very true. That's why that's one of the cautions, because we still do not have full control over the pathways of differentiation, right? And so this is one of the main risks, and that we have to be very, very cautious about.
In the hope that in the near future, this thing to be overcome, you mean, by further research?
Right, and that really is a major warning for us, not to take these stem cells and just inject them anywhere, right? Because we see urologists placing them in the testicles and physicians in the ovaries.
Thank you. I think there was one question earlier, but I think it was withdrawn, but I thought I will just mention it.
No,
Dr. Hannah Shabana, she's saying, are there any studies focusing on lifestyle changes that could possibly enhance the quality of the egg and the sperm? So I'm sure lifestyle affects the egg and the sperm, but are there any studies?
I answered this directly by text messaging the person who wrote, but my opinion is there isn't any study that can show that lifestyle affect quality of egg positively. But we know that it can affect eggs negatively, say if people indulge in excessive smoking or they have bad lifestyle in any way, shape, or form, but you cannot claim that there is any intervention that can affect the quality of the egg positively.
Thanks. Can I ask Dr. Johnny Awad about the ASCOT trial or the ASCOT study? You mentioned that the euploid rate was very low, strikingly low. Now, my question is, from the methodology of the study, do you think it's an age factor or because of the POI itself or the poor result? What do you think?
Yeah, it is very, I mean, very little data are there in this study about the demographics of these patients. But if I'm not mistaken, the age was something like 36 plus, right? So that's very unusual at this age, right? And I don't have an explanation for that.
That's what I thought.
But I think the question mark that we have to keep in our mind is that it does not improve really the euploid rate or the quality necessarily, right? If anything, some numbers, if proven.
Okay, I think we're getting more questions coming in. I don't know if Dr. Hazem want to read out.
I'd like to ask both speakers to say, how do you see these technologies in the near future?
I agree with Dr. KHALAF. I think PRP is a shot in the dark, right? Because if you again review the endometrial physiology or implantation process, and you look at all these cytokines, the interplay between the cytokines, between the Th1, Th2, immune profile, right? You see, these are essentially the same interleukins, same growth factors, but with different predominance, right? Now we're undermining the whole process of implantation by pouring in the system a huge amount of these interleukins and expecting an outcome, right? And there's a very interesting study out there that have shown that the concentration of PRP in the bovine model can really flip really the whole clinical picture into either proliferative or inhibition of proliferation. So there's some preclinical studies that tell you PRP should be very cautious. When it comes to stem cells, I'm really very hopeful that in the last study from the Brigham and Women from Harvard University, if there's more that can be done along the way. Of course, there's a long way of proving efficacy, proving safety. So there's a long way before we can really consider applying it, maybe for another decade, right? But if more is invested into this, there could be a way to rejuvenate these stem cells or make them differentiate into oocytes that are functional and potentially can result in healthy pregnancies. I mean, there's potential there, but we're far from that.
Thanks, Johnny. Thank you, Johnny. There's two questions coming along now. One actually, which Dr. YACOUB declared that in the beginning that he will not cover the endometrium with PRP, but I think there is a burning question from Dr. Amr Mitwalli, about the role of PRP, maybe just a couple of words about the role of PRP in recurrent implantation failure in suboptimal endometrium. So, Dr. YACOUB.
I think those who know a thing or two about recurrent implantation failure will accept that the majority of cases of recurrent implantation failure are due to embryonic factor. The studies have been shown if you replace 5 eubloid embryos, as long as the uterus is morphologically normal, the chance of recurrent implantation failure is 2%. And that gives you all you need to know about the contribution of the endometrium. So there is no place for immunology. There is no place for endometrial receptivity testing. They all have not been supported by credible evidence.
Okay, thanks, YACOUB. There is a question from Dr. Abir Ennab. She's the president of the Jordanian Society of YNG. She asked about where are we today? I think that's to Dr. Johnny Awad. Where are we nowadays in terms of the use of cell therapy in a clinical practice in reality? Where are we? Are we still in the research process? Are we in the practice, real practice? Thank you.
Yeah, we're way into the research process, of course. As you can see, these 10 studies are all phase 1, phase 2. And most of the preclinical studies did not show an improvement in outcome in terms of pregnancy. It was mostly improvement in some follicular development or markers of ovarian response. So even the preclinical studies show some promise, but very limited. But we cannot, I think, extrapolate to clinical trials, to clinical applications before the trials come out and show the actual data.
And there is another question from Dr. Ahmed Al-Daman to Dr. YACOUB. Do you think we need to do more studies on PRP, or we had enough? We reached the conclusion, or do you think it's justified to keep doing more studies?
No, I think we have not done enough studies. Yeah. And although my inclination that the studies will be negative, but they will be just as useful as positive studies to confirm to people they are selling snake oil. They are taking the money and giving the patient nothing in return other than the potential of ovarian abscess. Yeah,
I think you're right. I think women are giving too much hope.
Yeah.
When the
no, we have to support them. It is very really disheartening to break their hopes, but we also have obligation to be honest and to say it as it is. I give an example. I had a patient a few months back, maybe 4 months, who had AMH of 2.4 picomole, which is about maybe 0.3 nanogram, and she was 42. I told her, your best option is really that I refer you to Spain to have donor eggs. She said, we will consider this, but I have money for 3 attempts using my own. The first attempt, she did not respond at all for a decent stimulation with combination of recombinant and HMG, etc. And then the second cycle, she produced only 2 eggs. 1 embryo, 3 cells was put back on day 2, nothing happened. The third and final cycle for her had 2 eggs. 1 embryo, 4 cells was put back inside her uterus. She is 16 weeks pregnant. So the best thing is to prepare the patient for realistic expectation, and they take their chances as low or as high as they come. But I can assure you, when I'm dead and buried, people hope to remember me. All of these add-ons, they do add nothing to the patient. They only deprive her of much needed money to try another cycle.
Just a couple of personal questions, if I may. Yeah. One from Dr. Nimr Al-Kafri, who is saying that, do we have centers in the Arab world doing stem cell transfusion? Ascot, do we have? Dr. Johnny? Or is it just outside in Europe or America?
I don't know of any. I'm pretty sure some are doing that, but I don't know specifically some. Right? To tell you the truth, we are interested in developing a research program along these lines using the EVs, right? and see what can come out of that. But when you do it as part of a research program, it means patients that are enrolled there, you offer them the treatment for free based on the research funds, right? You don't charge them, right? And that is really the difference between a center that does it for research, where you try to improve your methodology to find out if you, by improving your design, you can get to an outcome, or a center that is interested in the commercialization and the financial, and therefore they use the same protocol for everyone, irrespective of the outcome, right? So there's no improvement there, right?
Yeah,
So,
the other personal question is from Dr. Salama Hamid, our colleague from Iraq. She's asking if either of the speakers actually use PRP in the ovary, or they're just presenting.
Do I look like someone who would use PRP?
Well, she's only asking. It's a personal.
I know, but also she's adding a second interesting question.
Yeah,
which
she's
I
adding, yes,
really,
I'm going to read it.
I really read the second question, which tells us all we need to know. People say, because the patient refused to go for donation, we have to give her something. I will challenge this now and forever. You don't have to give her anything, particularly when it is expensive and potentially harmful. You can inject her with saline if you like, but even this I will be against. But the fact she will not accept donation, it is not our gift to make everybody's pregnant. It is not our gift to mislead people, because it will, as we've shown from the data, it does do nothing.
Okay.
So
Dr. Khaldoon, I can see lots of people also are thanking the society for organizing this magnificent webinar.
Yes.
So I would like to, however, so to answer the question, I've never used PRP in general in reproductive medicine, and not to inject them to the ovaries. But then again, I want to look at it from a different perspective. I think we have not, in terms of using PRP for recurrent implantation failure and in placing it into the uterine cavity, I think it goes against all the principle of endometrial receptivity that we have learned over the course of several decades. So it doesn't make any sense at all, right? It's idiotic, I would say. But if you inject it into the ovary and hope to get some benefit, we have to remember that from a biological point of view, if you're looking at a subgroup of women who might have a borderline ovarian reserve, who's a young group, which means the euploidy rate is significant, is high. Would a PRP benefit this subgroup or not? I don't think we have seen studies along the line. Before, we closed the window on that. And I'm not encouraging in any way people to do it outside a research basis. But I think when we lump people together, different ages and different types of ovarian failure or insufficiency, sometimes we get studies all over the place and we cannot even interpret them. But should we really consider a randomized, well-designed studies in women who are really borderline and see if putting these growth factors inside would, in a way, reactivate an ovary that's not already, that did not undergo the irreversible process or not, right? I don't know, Professor KHALAF, if you think a randomized trial with a very well-targeted group of women would be required at this stage. I hate to just generalize it across the board, because not all women are the same, and not all stages of premature ovarian insufficiency will be the same.
The call for a randomized control trial will always have my vote.
Right.
But number one, we do not help ourselves by selling any intervention before we study it, because it polarizes people. Those who believe for scientific or commercial reason that it works will never randomize. So they are undermining the process. Plus, I believe in biological plausibility. I can see no biological plausibility that will increase the number of depleted eggs or will make aneuploid embryos euploid. That already people need to appreciate that the better eggs are used first. What is remaining will always be of poor quality, and that is not reversible. That's my stand, but I could be wrong. Yeah.
اسمح لي.
I don't know what's happening in the current Arabic world, but I know in Jordan, some people, not myself, are very keen on doing PRP
everywhere.
and doing
Everywhere.
hundreds of cases.
Everywhere.
My question, that why don't they come up and share their results? Because it's one thing is
Which result, Khaldun? Their bank account or PRP?
Well, the PRP.
I'm sorry. Yeah,
Yeah,
but there
that's
will
what
be
I'm
no
saying.
result. There
Well,
will be no
exactly.
result.
That's why maybe but why they keep doing them, YACOUB?
Because it is good. The patient is asking, and there are some
Yes,
people
yes.
who subscribe to giving the patient what they want, not what they need.
Yes.
And that will not change whether it is in London or in Amman or in anywhere in the world.
And I think we should distinguish between a poor ovarian reserve, where women have maybe few, follicles and low AMH, and people who have complete ovarian failure. And there are people with FSH of 100 and people with AMH of 0, and they're still having PRP. And I think it's time to stop.
But Khaldun, I showed you in the example that I showed, the patient had completely different response and yield of blastocysts without being given polymint, nothing.
Yeah.
If you give her something, you will always attribute it to it.
Yes.
If we can't be objective, really, we will harm our patient, even though our intentions may be good.
Yes.
دكتور خلدون اسمح لي.
تفضل دكتور مروان، تفضل.
أول شيء يعني مرة ثانية أشكر، يعني حقيقة أشكر السبيكرز، يعني اخترنا هالموضوع لأنه هذا حقيقة رح يقوم الممارسة الطبية بالوطن العربي. أنا كما أسلفت هذا الموضوع انتشر مثل النار في الهشيم في كل الوطن العربي للأسف، وأصبح المرضى يطالبون، يعني بيجوا بيسألوا الطبيب إنه اعمل لي PRP. يعني صاروا المشكلة دكتور يعقوب هو البلاك ميديا، هو الإعلام الأسود اللي انتشر بدون evidence based medicine. وإضافة إلى ذلك بعض المجلات اللي نحن بنسميها المجلات المفترسة البريديتري جورنال نشر الكثير من الكيس سيريز أو الكيس ريبورتس إنه في فائدة. نحن عملنا حقن وحملت المريضة. طبعا ما في واحد منا إلا ما في إذا عنده يعني ovarian insufficiency ممكن تحمل، يعني بشكل طبيعي. يعني ماله هو لا يمكن عزو هالحمل من الPRP. إضافة إلى ذلك أنه الموضوع صار في مبالغة، صار في حتى اللي عنده FSH 70 تعمل PRP، وينشر على مواقع التواصل وعلى اليوتيوب كيفية حقن الPRP بالمبيض، حتى تاريخ هذه اللحظة حتى ضمن الرحم لا يوجد دليل دامغ على الفائدة مثل ما تفضلوا السبيكرز. لذلك والأصعب من ذلك هو انتشار حديثا اللي بلش شوي الناس ما تقتنع بالPRP، حول على الستيم سيلز، صار ياخذ الستيم سيلز وجابوا أجهزة من الشحم ويحقنها بالمبيض. تعرفوا يعني هذا الموضوع مو بس إجراء غير مفيد، قد يكون ضار. بالخصية قسم منه صار يتحول لتيراتوما أو يتحول لماليجنسي. فيعني حتى أخلاقيا إيثيكالي ما بيجوز تعمل بحث على الإنسان، فما بالك على مباشرة بدون أي تجارب، يعني خلينا نقول بري ميديكال أو بري كلينيكال دغري على الإنسان. الأصعب من ذلك الPRP لسه انتشرت في سوريا والعراق وشوي بالأردن وفي لبنان بالخصية، يعني يحقنوا الPRP بالخصية. وتعرف هي أحيانا ممكن تعمل يعني بلوك للميوسيس 2، يعني مو بس ما بتفيد بتضر. يعني أنا دائما أقول ليس يعني كذلك تورد الإبل، حتى للبحث العلمي غير مقبول، حتى للبحث العلمي يعني في لجان أخلاقية يجب أن توافق على ethical committee على لذلك هذا الموضوع. أنا بدي أحكي للدكتور يعقوب، أول بحث قدم في القشري بهلسنكي، بالقشري تبع هلسنكي، كان من فريق من اليونان، وهذا أول مرة تقدم. وللأسف نفس البحث قرأته بعدة محلات بالبلاك ميديا. أول شيء حكوا إنه زاد عندهم الميتافاز 2، بس هذا اللي طلع معهم أول مرة إنه قدروا يحصلوا. تاني هالبحث نفسه طلع وراها نفسه نشر إنه صار في حمل ل40% من المرضى ولا 30% من المرضى. المشكلة إنه بالطب ما فيك دائما تقول هالإجراء هو عمل الحمل. فيعني مثل تماما يعني الموضوع السبب والنتيجة ليس بالأمر سهل. نحن اخترنا هذا الموضوع حقيقة، مشكورين جدا. وفي ثواب كبير، لأنه المرضى أو مثل ما بقول يعني ما بيجوز نستغل حاجة المريض أو يعني رغبة المريض أحيانا بيجي يقول لك يا أخي أنا قبلان جرب علي، ما أنا قبلان لأنه أنا ما عندي مشان الحمل ومشان رغبة بالحمل بيتقبل أي شيء أحيانا وممكن يدفع أي شيء. في بالأردن مركز بيعمل ستيم سيلز، يعني انا اعرف في مرضى باعوا الاثاث تبع المنزل وباعوا البيت تبعهم مشان يروحوا يعملوا ستيم سيلز، لانه هو عنده نون اوبستراكتيف ازوسبيرميا وهو عنده احيانا سيرتول سيل اونلي سيندروم ويحاول يعملوا. يعني انا اللي مرقوا علي خلينا نقول عشرات او فما بالك يعني هذا نوع من استغلال حسب. لذلك هذا الويبينار مهم جدا انه وراح ينشر للوطن العربي لحتى الناس تعرف انه ايفيدنس بيس ما في شيء، وما في ما في ولا لا بي ار بي ولا غيره بيصنع بيوض او بيخلق بيوض جديده. يعني هاي النقطه اللي انا سمعتها من الدكتور يعقوب في المغرب، انه هذا الاجراء ما راح يصنع بيوض جديده ولا راح يولد بيوض جديده اكيد. يعني هاي نقطه مهمه، وانا يعني بتشكر كثير المحاضرين لانه حقيقه خطوه في الطريق الصحيح وخطوه لنبعد عن البلاك ميديا وعن ما ينشر ويعني يعني المشكله هي الادعاءات انه هذا الحمل نتيجه بي ار بي، هذا الولد جاب التوأم ثلاثي نتيجه بي ار بي بالخصيه، كله هذا لازم نبعد عنه. وانا الكل عم يسمع من الاطباء يعني حقيقه هو انا حتى تاريخ هذه اللحظه طالما ما في دليل علمي دامغ هو يعتبر سوء ممارسة على الإنسان. وهذا ما بعرف، أنا بتمنى يعلق عليه الدكتور جوني والدكتور يعقوب ريثما يصير في دليل علمي دامغ. ونحن ما زلنا ما قلنا بالسكند فيز، يمكن ما زلنا بالبري كلينيكال على حيوانات التجربة بكثير من الأحيان.
There's a couple of questions. Sorry, can I just we go to this because there's a couple of questions from Dr. Abdulillah Al-Farraj and Dr. Imad Al-Shara. Very short questions, but I think they will be related to what Dr. Marwan is saying. Dr. Imad Al-Shara is saying, were there any real studies after ASCOT, or was it the last? Because ASCOT was very attractive study and successful, but according to Dr. Imad, after that, apparently there were no more studies. Is that true, Johnny?
Yeah, I think these are the two studies that I've presented. I tried actually even today to update my data. I could not find any. There's one study actually from Iran, right? But again, the design is very loose, right? It's very hard to really make up much out of it. So these are the only 3 studies I could find clinically that has been published.
Sure, thank you. Dr. Abdullah Al-Farraj is asking Dr. Yaqub, do you think, I mean, I know you don't believe in PRP anyway, but I mean, for people with AMH of 1, he said, people who have some function, but they want to prolong their function. Do you think there is any place for injecting PRP? I don't think we can hear you, Yaqub. I think you are muted, Yaqub.
Absolutely no chance, because if it doesn't work biologically, it shouldn't work. But physiologically, it shouldn't work. Materially, for the studies that have been published so far, 2 decent studies suggested that's absolutely of no value. And I take this opportunity, Dr. Khaldun, إن أنا أستعطف. إحنا كلنا يعني كلنا في الوطن العربي، اللي يعرف واللي ما يعرفش واللي معرفته قليلة، العذر بتاع ان العيانه ما قدامهاش وسيله تانية وبتستعطفني وعايزاني اعمل لها حاجه، اسيبها ما اعملهاش حاجه. يعني مش عارف اتوسل اليكم ازاي. مش احنا اللي بنخلي الناس تخلف. الحاجات دي بايد ربنا. حتى انت لو ما اديتهاش حاجه ربنا رايد لها يحصل لها حمل، لكن مش مبرر عشان نديها حاجه مكلفه ما لهاش اي فايده وقد يكون لها اضرار. يعني لازم الواحد يحط ضميره على المحك.
شكرا تماما.
I think that also answered Dr. Marwan that about really we should be very, putting brakes on this and not really, just keep doing more cases. Dr. Abir have just informed you that there is one place in Jordan which is doing transplantation, of stem cells, but only in research. So it's not sort of a practice.
دكتور خلدون، لو معلش لو ان انا عايز يعني بس اقترح اقتراح. لو الدكتور اللي ما عرفوش ده واللي هو يشكر ان هو بيفكر في الريسيرش did not publish his protocol for research before starting the research, he will be wasting his time and patient time and money.
Yes. Okay.
دكتور
Any
معلش
comments?
دكتور خلدون انا تابعت موضوع الستيم سيلز.
Yes.
للاسف سجل على الانسان 2 كلينيكال ترايل على clinicaltrial.gov. واحده كانت من الاردن وواحده كانت من مصر الشقيقه. بس التنتين اوقفوا اخلاقيا لما صار في لانه ما سيف انه ينحقن سواء بالقصي او ما وصلنا لمرحله السيفتي. لذلك حتى هدول بلشوا فيهم واوقفوا لانه تبين انه فيهم ضرر. لذلك حتى الكلينيكال ترايل يجب ان تسجل وتنشر وتاخذ ملاحظات. هذا الشيء ما عم يصير للاسف. لذلك حتى فور ريسيرش يعني عليه كويستشن مارك، لانه يعني يجب ان تجرى الابحاث بالاقنيه الطبيعيه والسليمه للبحث العلمي والامنه للمريض حسب شروط هلسنكي للابحاث كلنا بنعرفها. فيعني قولا واحدا يعني الموضوع يعني يحتاج الى خلينا نقول تبصر.
Dr. Hazim, what do you think from your perspective about what's been said? What do you think?
طبعا I'd like to thank both speakers. This is a very sensitive issue, and as all of you said, that it is a practice, unfortunately, without strong evidence. طبعا you cannot play with the emotions of the patients, and because they are under pressure to reproduce, especially in our area. So we should not, introduce anything to clinical practice unless it is proven, supported clearly by clinical randomized trials that it is effective to patients. And we don't try on our patients, and because this will cost them a lot, and at the same time of no actual use. So that's my opinion. The judgment is adjourned, and we have to wait for a really proper research that proves that this is really, successful for patients before trying it.
This actually has bring me to a question from Dr. Salim Abu Khuzairan from our dear Palestine. He just said that really, shall we just wait for more studies, which might take many years, and these patients are hanging onto any hope, or do we just use something? And I think at the end of the day, we must just have to wait. But some people want to do anything, and doctors feel the pressure because they feel they have to do something. Well, not all doctors. Some doctors that just refuse to give this service, and I refuse it myself. If I may, say what an Arabic saying, يعني أمثال عربية. I think it all goes back to experience and judgment from the old days, from my grandparents, and they always said that الغريق بتعلق بقشة. The people who are drowning, they will hang on to even to a straw. They will hang on to anything, but the straw, unfortunately, never saves. Unfortunately, I think this is probably what's happening. So, any more comments, Dr. Marwan? Do you want to conclude?
والله أنا يعني بتشكر الجميع، بتشكر المودريتر، بتشكر السبيكرز. الموضوع جدير بالاهتمام، وأكيد رح يكون له فائدة للجميع، على الأقل تقويم للممارسة الطبية بالوطن العربي. وهذا هدف طبعا الاتحاد وهدف كل الجمعيات، هي تحسين نوعية الممارسة. أنا بتشكر من أعماقي البروفيسور يعقوب خلف، بروفيسور جوني عواد، بروفيسور حازم رميح، بروفيسور خلدون خمايسي. بتشكركم من الأعماق لتسليط الضوء، وإن شاء الله نلتقي في خلينا نقول ندوات افتراضية قادمة. يعني اسمحوا لي باللغة العربية، خلينا دائما نعزز اللغة العربية بالوطن العربي. شكرا جزيلا للجميع، وإن شاء الله لقائنا في الويبينار القادم، وإن شاء الله بنضل مع بعض. وما بعرف إذا المودريتر لهم أي تعليق. أنا بتشكركم، وكانت فعلا الجلسة أكثر من رائعة، وتشفي يعني خلينا نقول أو تجيب على الكثير من التساؤلات اللي وصلتنا سابقا. شكرا.
دكتور مروان،
دكتور
الدليل
أحمد.
على نجاح الويبينار هو المشاركة والأسئلة.
الحمد لله.
نحن نشكركم
يعني
جميعا
أنا
بصراحة.
أعتقد أنه معظم العاملين في الخصوبة في الوطن العربي شاركوا بشكل أو بآخر، دخلوا وخرجوا بالنتيجة، شاركوا، مشكورين جدا طبعا جميعا. شكرا لكم. ما بعرف إذا الدكتور أحمد عبد الواحد معنا انضم لنا، إذا بحب يعقب.
شكرا لكم
أحمد.
جميعا، ويبنار رائع متشكر جدا. شكرا دكتور يعقوب، شكرا دكتور
شكرا جزيلا.
عواد، بارك الله فيكم، نراكم دائما على خير ومحبة.
الله يبارك
Thank
فيك.
you very much. Have a nice.
شكرا
كل سنة وانتم
للجميع.
طيبين، رمضان كريم، كل سنة وانتم طيبين إن
كل
شاء
عام
الله.
وأنتم بخير
كل سنة
جميعا.
وانتم طيبين. كل
كل
عام
عام
وانتم
وأنتم
بخير.
بخير. شكرا جميعا.
ألف
عام
سلامة.
كل
وأنتم
سنة
بخير.
طيبين إن شاء
مع
الله.
السلامة.
بارك
مع
عليكم
السلامة.
الشهر.
مبارك.
ألف
يوم
سلامة.
الله.
مع
شكرا.
السلامة.
وانتم بخير.